All right, going to talk about chapter 28, abdominal and gastrointestinal disorders. This is going to be out of your Sanders paramedic textbook. This is not an incredibly long lecture, but it does have a whole lot of information. Make sure you're reading your book, and there are a ton of terms that you need to be familiar with, and we'll get into them as we work through the lecture. Obviously, this is going to incorporate our assessment findings and understanding pathophysiology to come up with a field impression. And remember that a field impression really just means what a paramedic thinks the diagnosis will be. And we're also going to work to develop treatment plans and a disposition plan for the patient with medical complaints. Just a real quick review of gastrointestinal anatomy. It's important that we understand how this works. When we first take in food, and we're just doing a kind of a broad overview, when we first take in food, um, when you are chewing, the actual act of chewing is a term called mastication. Mastication. What you're doing is you're breaking down that food. The saliva is starting to assist with the digestion of the food, and then you will swallow the food. The food will go to the stomach, and there, very, very strong acids will begin to break the food down, and simultaneously, your stomach will turn the food around, churn it. And this will mix the acid in the stomach. It will mix the saliva from the oral pharynx, and your chewing or your mastication has broken down that food into smaller, easier to break down bites. And that will create a substance called chyme, C-H-Y-M-E. And chyme is it's kind of a sludgy type deal, and that is how you will then send that food, the nutrients, from the stomach into the small intestines, into large intestines where absorption of nutrients goes, and then the waste products will then be expelled out of the body. Now, that is the way that it works, okay? And there are a lot of things that will happen throughout this that can go wrong. So you will hear me say, and you will hear other people say, that abdominal complaints tend to be kind of the great mystery in medicine, and that tends to be the case. Now, there are some things that you will definitely have to understand from the perspective of there are myths that exist and are still out there about abdominal emergencies, and there's things that are not valid anymore. And we're going to talk about those, but the big one that I want you to take away from this is back in the day, absolutely back in the day, you were not to treat an abdominal emergency with narcotic medications or pain relievers. The reason that existed back in the day to do that is because 20 years ago, even, there was not the ability to have a three-dimensional CT scan or really detailed ultrasonography that exists. We have those now. And the reason that that mattered back then was where your pain was and how your pain felt, and all of those indications that the pain gave us were important diagnostic indicators. We don't need that anymore. We can run a CT, and in 15 minutes, we have a complete map of your abdomen. We can do an ultrasound at the bedside. So it was very important, even 20 years ago, even 10 years ago, to not blunt pain, because pain was a good diagnostic tool. Now we want our patients not to feel bad. So you will hear old medics tell you we don't give pain medication to people with abdominal complaints, and that is just not the case any longer. That is absolutely not the case, and you absolutely should not do it. And the National Registry will place a very big emphasis, very big emphasis on you making sure that you are treating your patient's pain. So please be aware that that is something you need to do. Narcotic pain medications are absolutely indicated, but do make sure that your patient is hemodynamically stable, because many of these conditions we talk about will create hemodynamic instability. So make sure that you're doing that. Please understand that. Now, we do need to know some things, and we just kind of have to memorize this, but if you can see here, and let me try to get my highlighter to work for you. I'll just use my laser pointer. You see here on your slide, you see that where the umbilicus would be creates 4 quadrants. Now, as a person who holds an EMT license, you should have this information memorized. But if you don't, now is the time to understand that you do need to memorize the 4 quadrants, okay? The 4 quadrants are very important when you're assessing, because you need to be able to know what goes where, because it will help you determine what is wrong, okay? So make sure that you understand what falls into what quadrant. Your book has a good chart for this, but please understand that. Now, that will be on a test, and you will see it coming up, okay? So understand your quadrants and understand what goes where. You have your right upper quadrant, and I'm going to right upper quadrant, and you can write that just like so. In the right upper quadrant, you will have your liver, okay? Largest organ in the body. You'll have your liver, lives right there. Right underneath the liver, it kind of tucks up underneath it. You're going to have the gallbladder, okay? And then you'll have quite a bit of the intestines, and you will find that the intestines are in all the quadrants, but those are your two main organs that you'll see in your right upper quadrant. In your right lower quadrant, you will have more of your intestines, and you will have the appendix, okay? In the left upper quadrant, you will see that the majority of the stomach lives in the left upper quadrant. Also, the spleen, right there, lives in the left upper quadrant. And in the left lower quadrant, you will see the colon and, again, much of the intestines. Now, if the patient is a female, you obviously will have two additional organs in your right and left lower quadrant, and those would be ovaries, and that is an important thing when you are diagnosing or treating a female patient. Is there a chance for ectopic pregnancy? So you need to ask if the patient's been sexually active, their last menstrual cycle, and if there is any chance they are pregnant. Diagnostically speaking, when you have a female patient of childbearing age, whether they admit to being sexually active or not, and they have lower quadrant pain, you have to rule out the likelihood of pregnancy. So that is very important. And then coming to the main line, the rectum and the anus are in the main line of your abdominal quadrants. Now, you need to make sure that you know that. It's very important to understand that. Now, when we talk about the stomach is an expandable organ. Okay, so it can expand and contract based on how much food you put in it, and it lives almost exclusively in the left upper quadrant. Okay, understand too that when we're talking about the abdominal quadrants, the diaphragm, which is the big muscle, let me clear some of this off, which is the big muscle that helps us breathe. We should all know that by now. The diaphragm, which is the big muscle that helps us breathe, it is the upper boundary to the abdominal quadrant. So this is the abdomen. So anything superior, meaning going up, anything superior to the diaphragm would be the thorax, or the chest. Okay, that's very important for you to understand. Now, the stomach, like I said, it mixes with your digestive juices, which are very much acids, and it creates this mass called chyme. There are lots of things that are going to happen within the stomach, but its primary focus in life is really to prepare that food to go into the intestine so that it can be absorbed into the intestinal tract. That is why when we talk about people who overdose on medications, activated charcoal is not effective after 30 minutes up to an hour, because that medication's already made it out of the stomach into the intestines where absorption happens. All right. As you follow the stomach down, what you will find is there's something called the pyloric opening, and it's between the stomach and the small intestines. Now that's where everything is connected. There's something there called the pyloric sphincter. The pyloric sphincter can sometimes get stuck open, and if you've ever heard of pyloric stenosis, that is where that happens. Okay, and that happens quite a bit in children that you will find as well. Okay, some of the chemicals that you'll see in the primary chemical that you see in the stomach is something called hydrochloric acid. It's going to break down the food, and you'll also see pepsinogen. Pepsinogen is an enzyme, and it helps break down the food. Now, pepsinogen actually isn't active until it gets exposed to your hydrochloric acid, and then it becomes pepsin, and pepsin breaks down proteins. So when you're in the ER, and you'll hear lots of times they'll give medications that'll help break down or help with stomach acid and things like that, and that's the background of how that tends to work. Okay. So then we move on to your small intestine. It's the longest part of your digestive tract, guys. You need to understand that. It's the primary side of your food digestion and that absorption of nutrients, and that's important to remember. Um, it stays lubricated with secretions, and that helps keep the intestinal walls from being impacted by that chyme, which is highly acidic, remember. Um, and it also will assist in continuing moving that food down into the, and it'll help keep that food moving, and what that's called is gastric motility. So the constant movement throughout the digestive system's gastric motility, and that's very important. So there's three sections of the small intestine. So you have the duodenum, the jejunum, and the ileum. Okay, so the entire length of a typical adult intestine is about 24 feet. Okay, so the first part's called the duodenum, and it forms about a 180-degree arch within the abdomen. So it's kind of that big loop you see. The pancreas lives within that area, and then the duodenum kind of starts when there's a bend within this. And I know this is very hard to imagine this in your head, but then the duodenum kind of takes a little bend as it comes out of that C, and then you have the jejunum. And the jejunum has much, much thicker walls, and it's got more folds in it than the other parts. Okay, and then the ileum is at the last portion, and it comes on to become the large intestines. Okay, and then your large intestines have again a lot to do with um, digestion, and as it continues on in such a way that it will fill out and finalize the digestion, and then will allow for the secretions, or the excretion rather, the excretion of the waste products. Okay, and that's a brief overview. Let's talk about the gallbladder. Gallbladder is sac-like, so it's a hollow organ. Okay, and it's just a reservoir of your bile, which is one of those digestive enzymes that the liver produces. And that's why, if you look here, you've got the liver, right? And then here's the gallbladder. So you've got the juices, and that's literally what they're called, the juices that are produced by the liver, and the gallbladder is their storage unit. Okay, so that is what the gallbladder does. Now, you don't have to have a gallbladder. A lot of people have theirs removed. It does create some problems in doing so, but you can have the gallbladder removed. So let's talk a little bit about your solid abdominal organs. The liver, again, the liver lives in your right upper quadrant, your RUQ. It's the largest internal organ. Interestingly enough, it weighs about 3 pounds on most adults. Contains left and right major lobes, and it has a lot of storage functions for glucose, protein synthesis, which means making proteins, and it filters body waste. So you can't live without your liver. They can be transplanted, and because they're lobed, you can give a portion of your liver to someone else. The spleen lives a little bit behind the stomach. It's supravascular, and it's where a lot of our immune response comes from. And it handles red blood cell removal from circulation, so it breaks down that. The pancreas also lives behind the stomach in the left upper quadrant. The pancreas, remember when we talked about glucagon, that the islets of Langerhans live in the pancreas, and that's part of what helps with dealing with blood sugar issues. So the pancreas makes insulin, glucagons, and handles other digestive enzymes. It'll secrete insulin and glucagon into the bloodstream. So the pancreas has a big, big role in the endocrine system. Okay, so you need to remember that as well. And then let's talk a little bit about terms that sometimes confuse students: the peritoneum and the mesentery. So the digestive organs are surrounded by the peritoneum. It's a double-layered area of connective tissue. Okay, so the parietal peritoneum lines your abdominal cavity. Okay, and the visceral peritoneum is in close contact with your organs. Okay, so it's a sac and it surrounds that. Now, it's important that you understand the peritoneum is sterile. So if you have a rupture of an organ, and the appendix being the one that I would want you to think about more often, it's sterile, but once that appendix ruptures, you now have bacteria in a sterile space. So you have to think about sepsis and things like that. Okay. Your kidneys, your pancreas, the duodenum, and most of your blood vessels, your major blood vessels of the cavity, live behind the parietal peritoneum. That's known as a retroperitoneal space. Okay. So they don't live within that area. All right, and that's just good A&P knowledge to understand. Your mesenteries, they hold those abdominal organs in place, and they are what allows the passageway for your blood vessels and nerves to those organs. Okay, and that's important to understand. If you ever see a surgery about this kind of stuff, you'll see a lot of that, or hear it talked about quite a bit. Okay, so I know that's a little bit more A&P than maybe what you are used to, but I'd encourage you to go back and read that if you're not super confident with how the abdominal organs work, because it's important that you know that. So moving on to your assessment of your patients with acute abdominal pain. Again, acute means sudden onset. Obviously, ensuring scene safety, we shouldn't have to talk about that, but we need to make sure that the scene is safe. Next, determine whether your pain of the patient is a result of trauma or a medical condition. If it's trauma, that changes things we look for. And then we need to determine mechanisms of injury. If it's a medical condition, then we slide back over to that medical assessment. Do a good primary survey of your scene. Ensure that you're safe to see if there are clues to what's going on present. For example, pill bottles, Pepto-Bismol, things of that nature laying around, something that will clue you in and help you refine your field diagnosis. Obtain a thorough history. Focus on your chief complaint. If you have right upper quadrant pain, that's where you need to be paying attention to. But don't get too hung up on that. Make sure you're doing a good, thorough assessment, but that should be where your focus is, but not entirely your focus. Does that make sense? You need to make sure that you're not missing something, okay? So make sure, like I've said many, many times, make sure that your symptoms match your complaint, and your symptoms and your complaint match your vitals and your other findings. Okay, don't tunnel vision. Okay, get a baseline set of vital signs, and then do a systemic physical exam. Let's talk about history. The OPQRST mnemonic is super important for you guys to understand. It's super important that you understand why to do it and to do it. Okay, so for onset, when did that pain start, guys? Was it sudden? Was it gradual? Sudden onsets, usually you're talking about perforations of organs or capsules. That general onset, a lot of times, is blockages of your hollow organs. Okay, and that's not always the way it is, but that's kind of where you want to lead your mind to first. So, if you have a sudden onset of abdominal pain, a lot of times consider that a perforation, like small bowel, things like that. If it's real gradual, then that's a blockage. That could be food blockages. That could be not having good blood flow, things like that. Okay. Provocation and palliation. Okay. What makes the pain worse? What makes it better? And this is kind of anecdotal, but if the patient tells you that their pain gets better when they draw their legs up to their chest or they lie on their side, a lot of times that's a sign of inflammation in the peritoneum. So that's kind of a GI, complaint. If they get up and they walk and the pain, gets better, a lot of times that's something in the GI tract, or that's a urinary symptom, like a gallbladder stone or gallbladder obstruction, or maybe a kidney stone, something like that. Again, that's kind of anecdotal, but you'll see that a lot. Quality. How would you describe that pain, guys? Is it dull? Is it sharp? Is it constant? Is it intermittent? A lot of times you'll see localized tearing pain. That kind of comes with the rupture of an organ. But if it's dull and it's steadily increasing pain, that can be bowel obstructions. Really sharp pain, especially if it's in the sides, that's kidney stones more often than not. Okay, and a lot of times you can kind of chalk that up to history. If the patient's not a big water drinker, things like that, or if they have a history. The next part here is region and radiation. Does that pain travel anywhere, right? Pain that radiates or tries to travel places, that has to do with the neural routes in embryonic development. So as you're developing as a child, you create these neural routes, and it kind of links back to dermatomes. So even though the referred pain doesn't make sense, or the radiated pain doesn't make sense to us, it's actually following nervous system routes that were designed when we were in embryonic development. Okay, so for an example of that, a lot of times if you see neck pain or shoulder pain, um, it's associated with an irritation of your diaphragm, right? Well, it's not a diaphragm problem, but that happens with cholecystitis, which is an issue with gallbladder. Okay, there's a really good chart about where referred pain is in your book, and I definitely recommend that you spend some time to make sure that you kind of commit that to memory, because it's kind of all over the place, and like I said, it doesn't really make sense to us uh, because these are things we can't see as far as why pain radiates. Severity. People don't put a lot of emphasis on this, but severity is very important. On a scale of 1 to 10, 10 is the worst pain possible, 1's no pain at all. How would you rate the pain? Okay. Know that the severity of your pain usually gets worse as the pathology, meaning whatever's happening, that could be ischemia, that could be inflammation, stretching of the organ advances. It's also important to get a baseline pain scale, because when you treat that patient with an analgesic, you want to know if it helped. So if you didn't get a baseline pain scale, you don't know if your pain medication worked. So if the patient tells you before pain medication their pain was at a 9, and then when you give them Demerol and they tell you the pain's at a 3, have you helped the pain? Yes, you have. Okay. When did that pain first start? Get a good estimation of that time. Okay. Generally speaking, if you have abdominal pain that's more than 6 hours old, it typically means that there's a high likelihood for there being a surgical emergency. Okay. And then we also need to talk about associated symptoms. Okay. Nausea, vomiting, right? And of course, this is your sample, but nausea, vomiting, right? Um, if they are doing some vomiting, let's try to figure out what's in that vomit. What's it smell like? The color, things like that. Find out if there's bright red blood in it. Find out if there's coffee grounds. Find out if there's clots. Okay, that'll tell you if you've got a gastrointestinal bleed. Let's talk about changes in bowel habits, constipation or diarrhea, right? Um, Especially in older patients, you'll see that they don't have good bowel movements, so they get constipated. That can have a lot to do with it, okay? And look for loss of appetite or weight loss. Usually they will have loss of appetite and they might have weight loss, and that's good to pass on to the emergency department. And then talk a little bit about pertinent negatives, and that's very, very, very important for pertinent negatives, okay? Um, you can, and MIs being the big one, okay? You have to rule out, and I talked about ectopic pregnancies, you have to rule out, or at least highly suspect, um, reproductive issues, but you also have to remember that an inferior wall MI will irritate the diaphragm, and it's going to generate that same referred pain pattern. So patients who have abdominal complaints typically need a 12-lead as a diagnostic tool, okay? So make sure that you're taking a look at that. On your sample history, really dig deep on your last oral intake, okay? It will help you differentiate different causes, okay? And it's also good to know, because if a patient does have to have surgery, the doctors need to know when they last had something to eat, okay? Know that things like heartburn, or what we would call gastroesophageal reflux, that causes chest pain. So do gastric ulcers. So does the duodenal ulcer. Remember, we talked about the duodenum. Where's that at? Okay. Gallbladder disease. Usually people having just eaten a really fatty meal, a lot of times will have chest pain, and that's the gallbladder having a little gallbladder attack. You need to make sure that you're doing a good job getting a 12 lead, ruling those things in or out. Okay. And like we talked about, inquire about any recent illnesses, past significant medical history, hypertension, cardiac or respiratory disease. What medications do they use? Are they abusing alcohol, okay, or using it? Again, last bowel movement and significant changes in bowel habits is very important. If they're not moving their bowels, they're probably going to have abdominal pain, and that doesn't necessarily mean it's a surgical emergency. They might not. They might just simply need an enema, or they might need digitally disimpacted, or they may have a legitimate bowel blockage and they need to be um, taken to surgery. We can't tell that in the field, but if we get a good history, we a lot of times can make a reasonable assumption on it. And menstrual periods play a good role. Uh, Again, location and type of abdominal pain. Seek to relate the anatomic location of GI organs and structures to the origin of pain. Okay, and let's talk about different types of pain. Okay, people kind of get hung up on the different types of pain, and it definitely can be something that's confusing. So let's understand visceral pain. Visceral pain is caused by stimulation of your nerve fibers, okay, that surround an organ. All right. And most of the time, those are your hollow organs like gallbladders, appendix, the capsules of your solid organs like your kidney or liver. Okay. You're going to see this come from inflammation. You're going to see this come from distension, which means it's being stretched out or inflated. And you're going to see it from ischemia, which is inadequate blood flow. All right. Okay. So your patient will describe this as a cramping style pain, gas style pain. The intensity varies, and a lot of the time it varies due to where they are in the physiological response. Very, very difficult to localize this, so it'll be diffuse. Some of your common causes are early appendicitis, pancreatitis, cholecystitis, and intestinal obstructions. Okay? Somatic pain is different in compared to visceral pain because it is sharp, okay, and it travels along those neural routes like we talked about, okay. Um, they're clearly defined. You can localize that pain to a particular region or area. A lot of times you see this in bacterial and chemical irritation of nerve fibers, and this pain is described as sharp or stabbing. And those two key differences, sharp and stabbing versus dull and cramping, will usually tell you the difference. But you can localize this in somatic pain. You cannot localize visceral pain typically. Okay, and talking about referred pain, okay, that just simply means that it originates in a region other than where it was felt. All right, and remember that those neural pathways kind of go all over the place and they don't make sense to us, but that came from embryonic development. Okay, so pain that you see in part of the body that's considerably removed from the tissue that causes the pain is linked, and that's that chart I told you that you need to look at. A lot of times your visceral ailments cause no symptoms except your referred pain, which makes it very, very hard to diagnose. Now, here you see that the shoulder neck tends to be the liver. Biliary colic is under the breast. Cholecystitis, pancreatitis, and duodenal ulcers are in the liver side of the body. Renal colic can be over just in kind of your stomach area. Small intestine pain can be around the umbilicus. Appendicitis, this is called McBurney's point, is just off from your umbilicus. And you'll see that you can have ureteral colic, which kind of follows the ureter there. Pancreatitis in the back, ulcers in the back, and these are both upper back neck areas. Pancreatitis in the small of the back, and you would think kidneys there, right? Renal colic, obviously there, and rectal lesions will be right just above the sacrum. So there's a lot going on there, and I know that's hard to look at and remember, but you do kind of have to throw that in the back of your mind because it is a good diagnostic indicator. Okay. So let's look for some of our signs and symptoms with the acute abdomen. Okay, so we have nausea, vomiting, anorexia, which means poor appetite. Those things that we'll see with appendicitis, biliary tract disease, gastritis, gastroenteritis, high, meaning in the abdominal tract or the digestive tract, high intestinal obstructions and pancreatitis. Diarrhea tends to be an inflammatory process, so you'll see that in gastroenteritis and UC. Constipations caused by dehydration, obstructions, and medication-induced decreasing of that intestinal motility, like we talked about. Narcotics, folks, people on narcotics tend to be constipated, okay? So be aware of that. So when you see this, you tend to think low fiber, okay? Low fiber or narcotic usage, okay? Okay, and elderly folks are the ones you will see that happen on most often, okay? More signs and symptoms. Changes in stool color. Biliary tract obstruction will lead you to clay-colored stools. Black tarry stools tend to be lower intestinal bleeding. Infectious diarrhea will have any number of colors, but it usually smells horrible and it's pretty dark. Chills and fever tend to tell us we have an infection, okay? Appendicitis, bacterial infections, cholecystitis, or pyelonephritis, okay? So kidneys, gallbladder, appendix, and this can be all over the place. Get vital signs, okay? Get a blood pressure, get a pulse rate, get a respiratory rate, take a temperature. Remember, these are sometimes infections. Get a temperature, skin condition. Generally speaking, get orthostatic uh, vital signs on these patients. That will tell you if you have a volume depletion issue. Okay, so find out if you have an orthostatic blood pressure and pulse rate issue. That'll tell you have volume issues. Okay. Um, you also want to assess your blood pressure, pulses, and cap refill in each extremity to make sure you're not dealing with an aortic dissection. Okay. Remember, can have a AAA, and you will have variations on your blood pressures and your vital sign findings if it's perforated, okay, or dissected. Okay. Inspecting these patients, note their position. How are they laying? How are they sitting? Take a look at their skin color. Look at their facial expressions. Look for the presence or the absence of voluntary movement. Inspect the abdominal wall for bruises, scars, ascites, which is fluid leading to abdominal distension, and abdominal masses. Those are all going to tell you whether you have a problem or not, okay? So look for it. If it's bruising, what do you think is going on? If it's bruising, you probably have bleeding going on there, right? If it's scarring, they've had a previous surgery, so they could have a complication from that. Ascites with abdominal distension tends to be liver issues, and abdominal masses can be tumors. It can be tumors. It can be a buildup of stool from an obstruction, or it could be a not yet ruptured abdominal aortic aneurysm. All right. You can auscultate to whether you hear breath sounds. It's kind of hard to do in the field. I'm going to tell you that percussion is not something that is very effective for us in the field, so I don't recommend it. You can feel to see if the abdomen's warm to the touch, things like that, but actually trying to do a percussive test is very difficult to do in the field. Now, palpation is very important, but you don't want to hurt your patient. So when you palpate, you want to palpate firmly but not too deeply and look for signs of pain. But you're looking for rigidity, you're looking for spasms if the patient's particularly tender somewhere, or masses, or if you feel a rebound on that. Okay? Very important to do that. I do want to make a point. If you feel a pulsatile mass when you are palpating, if you feel it or you think you feel it, stop. Don't keep digging around. Okay? That's very, very important that you understand that. You just let it go. All right? Also, when you're palpating, you always start furthest or the quadrant furthest away from where the pain is. Okay? Because if you point to where the pain is first and palpate there first, they're going to hurt everywhere else. Okay? So you start at the location furthest away. For GI bleeding, upper GI bleeds, pretty common. You'll see these with gastric and duodenal ulcers. You'll see it with variceal ruptures. Um, a lot of things that aggravate an upper GI bleed: NSAIDs, aspirin, chronic liver disease, blood thinners, underlying medical conditions. Your most common cause of lower GI bleeding is diverticulosis. You can see GI bleeding. It'll be mild, brisk, difficult to control. It's very hard to predict what you're going to see, but most GI bleeding is a true emergency because they will be bleeding pretty quickly, and it's very hard to control pre-hospital in the field. Some of your complaints you see with bleeding is cramping, abdominal pain, diarrhea, nausea, vomiting, obviously changes in your stool and bowel habits. Your patients can be anemic. They'll definitely be dizzy a lot of times. They'll be shortness of breath because of the ischemia, because they can't carry good oxygen because their blood's pouring out of their GI tract. If you have hematemesis with GI bleeding, it's very serious. These patients always need to go to the hospital. Okay. For you, GI bleeding, airway monitoring and management, particularly if you're experiencing a patient with esophageal varices, airway management is the most critical thing that you do. Emotional support because they're scared. If the patient is hypoxic, meaning oxygen saturation of less than 94%, then you need to administer oxygen. We typically like to get a lactate level. We can't do that in the field, but that is something that needs to be done. Get good blood glucose, as always, and get end-tidal carbon dioxide release. Okay? Acute gastroenteritis is an inflammation of your stomach and your intestines, and that usually comes from sudden onset. It's accompanied, rather, by sudden onset of vomiting and diarrhea. Bacterial or viral infections are common. Parasites, any number of things can cause acute gastroenteritis. You can see this with food poisoning, things like that as well. Usually very abrupt, very violent onset. The patients are uncomfortable. Our treatment's pretty much supportive, okay? We want to give them an antiemetic like Zofran or Phenergan. We want to give them fluids if need be, okay? If you're working in a disaster area, and it seems like we always are anymore, if you're ill, avoid patient contact. Check your water sources, or make sure that your water's been boiled or disinfected. And avoid habits that aid fecal, oral, or mucous membrane transmission. You can figure that out on your own. And if you don't, come see me and I'll explain it to you. Observe body substance isolation precautions, good hand washing techniques, and disinfect your equipment with appropriate cleansers. Let's talk about chronic gastroenteritis, and these are not the sexy ones that we usually see, but these are things that you pick up for all the time. Usually these are microbial infections. You can have hyperacidity, chronic UNSAIDs, things like that. Will give you chronic gastroenteritis. Your signs and symptoms are epigastric pain, nausea, vomiting, fever, anorexia, mucosal bleeding, and the patients typically are very tender in the epigastric region upon palpation. Treatment for this is dietary regulation, medications, and fluid replacement, and resuscitation is needed. IBD, or inflammatory bowel disease, describes two different types of conditions, ulcerative colitis and Crohn's disease. But it's chronic inflammation of the digestive tract, and over time, that inflammation causes permanent damage to the GI tract. So your most common signs and symptoms for ulcerative colitis are abdominal pain, fatigue, weight loss, anorexia, and bloody diarrhea. Okay? And for that condition, typically we're just going to take these people to the hospital and we're going to treat them as they are found. Okay, so as their conditions are marked. So if they need fluid resuscitation, we will resuscitate them, but there's not any one specific thing that we need to be concerned about. Okay, so we can treat them based on their symptoms. A lot of people kind of get confused about the term ulcerative colitis, and what it really means is it's an idiopathic disease. We don't really know why it happens, but basically, in most cases, what happens is these are just chronic ulcers that are happening in the GI tract, and as they heal and new ones are formed, you get a lot of scar tissue replacement, and that thickens that area and makes it very, very difficult for the patient. And unless the patient's previously diagnosed with ulcerative colitis or UC, which is the easier way to say it, you're not going to be able to really tell the difference between this and acute adjuvants. Okay, so if the patient tells you they have a history of UC, then that's very helpful. But past that, it's very hard to diagnose pre-hospital. It's even kind of hard to diagnose in the environment, hospital environment, because they have to roll lots of things out. Okay. Occasionally, you're going to see bloody diarrhea with these people, like we talked about. Like I said, if you have a patient who needs fluid replacement, it's going to be based on the fact that they're losing blood. We don't have a specific set of treatment for these patients. Okay. Definitely treat them with antiemetics if you need to. Consider pain medication if your protocols permit it to. Okay. So Crohn's disease, it's the other kind of idiopathic kind of inflammatory bowel deal. It's pretty common in the Western Hemisphere, but not a lot of other places. That probably tells you something about our diet. It has a pretty good genetic link. The thing about Crohn's is it can affect anywhere from the tip top of the gastrointestinal tract, so the mouth, all the way to the rectum. Okay. So it's different from ulcerative colitis in that sense. These people can have all kinds of problems, diarrhea to abscesses. They can have fistulas, which connect two different organs or different links of the intestine. All kinds of stuff goes wrong with these patients. As Crohn's continues to develop and as it goes on, you'll see that granulomas are going to form. They'll continue to break down those mucosal and submucosal layers. Those areas of that wall that's been affected by that become really, they hypertrophy, they get fibrotic, so they don't work very well. And so these people's digestive tract are just really, really really messed up. Um, your presentations for this, they vary dramatically, okay? A lot of what you'll see is GI bleeding, a lot of recent weight loss, intermittent abdominal cramping, um, again, nausea, vomiting, fever. These flare-ups, that's what they're referred to as really, they're pretty rapid onset, and these patients typically need to go to an ED for pain, okay? Pain control. The pain in the abdomen usually isn't localized because it's all over the place. Um, your exam typically is going to look just like all the rest of the exams. It's going to be like, well, it looks like it could be any number of things. So if they don't have a history or a diagnosis of it, you can suspect it, but you typically don't see it. You're not going to be able to pick it out of the lineup of everything else because it fits everything typically. Management of this at the hospital is going to be antibiotics and steroids, anti-motility agents, and dietary regulations. For you, you're again going to base that on physiologic status, vital signs, things like that. Antiemetics are your friend here. Antiemetics are always your friend. Fluids if they need it. Okay. So talking about diverticulosis, a diverticulum is a little sacral pouch and it develops in the wall of the colon. It gets more common as you age. Care of this includes high fiber diets, antibiotic therapy if they need it, surgical repair in some cases. And here's a good example of that. Those little pouches. The outpouchings of the mucosa and the sigmoid colon appear as little slit-like openings into the open bowel. Okay, and for the most part, we're not going to do much with that, guys. We're not going to have a whole lot to do with it. The only thing we need to do is make sure they're not bleeding profusely from it, and we would treat them with antiemetics if we need to, or if we have, again, abnormal vital signs that we need to do resuscitation on. Okay. So talking about appendicitis, so the appendix has no like true function that we're aware of within the GI tract. It's just kind of there. It's lymphatic tissue is actually what it is. And the reason that you see, and I think this is somewhere 10 to 20% of the adult population or the population tends to have appendicitis. Um, um, is a lot of fecal matter can get trapped in there. The reason that is where the appendix lives, kind of as the intestines are coming down, is it kind of creates this uh, kind of perfect storm of where fecal matter can get impacted, and then as it gets impacted there and is left there, it will begin to become um, inflamed because there's well, it's got stuff full of stuff it doesn't need, and then it will eventually become necrotic, and then there's tissue, bacterial tissue issues, and that blood supply gets cut off, and then you get ischemic, and then it becomes infarcted, and then it's necrotic, and then your vessel walls weaken, and then it ruptures. Now that's kind of the way it goes. So there's all kinds of things that go wrong. Now we don't typically see ruptured appendixes in the field. If you do, your patient's having a true emergency. So what we typically see is your mild or your early appendicitis issues. You'll see diffuse pain, meaning all over, colicky pain. More often than not, you'll see nausea and vomiting sometimes, and a low-grade fever with it. Oftentimes, that pain is initially it's located in your periumbilical region. Okay, so around the belly button, because of the way that blocks, those patients are going to lose their appetite. You need to remember that. But as that appendix continues to dilate, okay, so it's continuing getting bigger and it's continuing to grow, right? Because it's got stuff in it and it's got all this bacteria in it. That pain will start to localize in the right lower quadrant. So a right lower quadrant finding is later on in the appendicitis cycle. Okay, that's when I'm talking about McBurney's point. That's about 1 to 2 inches above your iliac crest along a direct line from your crest to your umbilicus. Okay, so it's over from your belly button just a little bit on your right side. McBurney's point. Okay. Now, once that appendix ruptures, that pain goes back to being diffuse. And the reason that is because all that bacteria and junk that was in the appendix is now in that what used to be sterile space, and now you have peritonitis. Now, that is a true emergency because those patients are going to be very, very, very likely to develop sepsis. Okay, so kind of recap, we get that obstruction because of passageways between the appendix and the cecum by fecal matter. We get a viral and more often than not bacterial infection as that fecal matter is growing in. We're dilating that out. We start to get bacteria in it. We lose good blood flow there. We become ischemic. We infarct. We necrose, and then we can rupture. Okay, so what you're going to see for your patient is that you're going to have some abdominal pain, right? And it's mild, okay? And it's all over, and it's kind of colicky, right? Nausea, vomiting, low-grade fever. And then that pain is that appendix begins to get closer to bursting, right? Okay? Or it gets hot, is what you'll hear a lot of people say, that you get a hot appy, right? That pain will get a little more localized in your right lower quadrant at the Brony's point. And then once it ruptures, that pain becomes diffuse again because you got peritonitis. Once you rupture, you got way, way more problems, okay? Your presentation doesn't always look like that, but that's the standard presentation. The goal is to get that appendix out before it ruptures, all right? So peptic ulcer disease. Now you're going to see this sometimes. It's a complex pathological interaction among various acidic gastric secretions and proteolytic enzymes in the mucosal barrier and digestive tract. Okay? So for us, we're going to evaluate for hypotension, provide circulatory support, and obtain a pertinent history. Right? You see this more in males than females. You can see this more often than not in your males and females, and you see these in your 25 to 50-year-old people. You see this with high stress jobs. There is some familial or genetic tendency with this. A lot of times this complaint happens at night or on an empty stomach. Okay, so that's why that history matters as far as getting there. People who take lots of NSAIDs, aspirin, ibuprofen, naproxen, are the ones that come off the top of my head, or lots of heavy drinkers, people who do alcohol and nicotine stuff, they'll make acid, are common to this. And people who have a lot of Helicobacter pylori, H. pylori bacteria, can be a good cause of peptic ulcers. Okay. You see H. pylori in about 80% of the ulcers anymore now that we've figured it out. Okay. So you'll see a lot of acute severe pain with these people. Again, look for hemodynamic instability, guys. It's kind of the key thing here. Fluid resuscitation, pain meds with your protocols allow for it. You will hear a lot of people mention ranitidine and famotidine, or proton pump inhibitors, and you'll see that in the hospital a lot, which will help out with that. Famotidine is over the counter and can help treat it. It's called Pepcid. Didn't know, but it's a histamine antagonist. Okay, so it decreases stomach acid production, which is why you have peptic ulcers. Okay, ranitidine is Zantac. Okay, so Zantac and Pepcid are your two that you see, and they give them in the hospital all the time. And then omeprazole and esomeprazole or some other ones that you'll see. Now, we don't give those in the field, just understand that that's something that will treat that. So a lot of times if your patient takes those, that's probably why they're taking them. Okay? But again, this is just one of those things that we're not going to do a whole lot with, but just be familiar with what's going on. Okay? So bowel obstructions, typically it's an occlusion because those lumens, so what gives the shape to the intestinal hole, if you're going to call it that, the lumen, meaning the hole, is blockage from some reason, okay? So you'll see that with nausea, vomiting, abdominal pain, diarrhea, constipation, abdominal distension. For us, that's going to be fluid replacement. It's going to be antibiotics, placement of an NG tube for decompression, and surgery if we need to. And we're not going to do that. Please don't do that. But that will be what you will see oftentimes happens with your patients. Now, as far as kind of some of the causes, one thing you need to understand is if you have a complete bowel obstruction, you have to worry about bowel infarction. If you have a bowel infarction, you have dead bowel. A lot of times this happens more in the small intestine because remember we're talking the lumen or the diameter of the hole, which is the tube, is smaller there. You can see this with tumor growth. You can see it with adhesion progression, but you need to be very careful with it because it can be very much a life-threatening complaint. Be aware that they're going to present with diffuse pain typically, okay? Um, so it's going to be visceral, very diffuse, poorly localized, okay? You may see them with hemodynamic instability because they may already be necrotic, okay? They may look shocking. What does shocking look like? Pale, cool, clammy skin, tachycardia, alterations in their LOC, maybe hypotensive, okay? Usually they're distended. A lot of times you'll have peritonitis or free air associated with that. Look for scars on them, guys, because if they've had a previous bout of this, that makes them that much more likely to have it again. Just don't be aggressive in your palpation, okay? Lightly palpate. This is going to be based on their support. Your treatment is going to be based on their support, okay? So you're going to treat this with fluids and medications if your protocols permit it. All right, so pancreatitis, you'll see this a lot. More often than not, this is caused by alcoholism. Okay, about 80% of this is caused by alcoholism. You see it all the time. Remember, it's a titus, so it means the pancreas is going to become inflamed. Okay, and when it's becoming inflamed, it's going to release those enzymes in the blood. It's going to flood the pancreatic duct. It's going to flood the pancreas itself. And you can see this being acute or chronic. And I'm going to talk a little bit about what that means here in just a second. Okay, because a lot of this comes from alcoholism, you typically will see an acute onset of this, okay? And the reason is it's kind of the way the pancreas is tissues arranged is we can kill these things if we produce too much digestive enzymes and we let it out, okay? We go from chronic, or acute rather, to chronic when we do that, when we kill those, what they're called acini, okay? And those are little structures that live within the pancreas, okay? The pancreatic tissue is called acini, and they produce those digestive enzymes that empty into the duodenum, okay? And when that happens, when we have that happen, when we flood it too much, okay, we get decreased blood flow, okay? So when that happens, we turn from an acute pancreatitis because we killed some portion of the pancreas to chronic pancreatitis. Now, when we go there, we're talking a mortality rate of about 40%. Okay, so remember that for chronic pancreatitis, those acini have to be dead. Okay, and you're going to see that go from acute to chronic, and that's usually due to alcohol intake. Sometimes you see it with drugs, but most of the time, alcohol. Okay. These patients can bleed, okay, because of this. A lot of times you're going to see nausea, okay. A lot of times you'll see uncontrolled vomiting, and that will help aggravate what you're seeing. So our treatment here is providing high concentration oxygen if we need it, because remember, if they're bleeding out, they're not moving oxygen out of their body, okay. Fluid challenges if we need to, if they're hemodynamically unstable. Most of the time, what we need to do, not pre-hospitally, but in the hospital, is what's called a gastric intubation and suction that area out, okay, which we don't do. A lot of times we'll do a peritoneal lavage, and this patient's going to get huge amounts of antibiotics, and a lot of times they'll have to go in and have surgery done. So pancreatitis is one of those things that you want to be on the lookout for. So I'm just going to kind of recap this because I know I kind of talked a little bit and I may have got in the weeds with you a little bit. So your symptoms for pancreatitis is going to be an acute abdominal pain, and it's usually on the left upper quadrant. A lot of times it's going to radiate to your back or your epigastric region. You're going to see nausea, vomiting. Sometimes you'll see some bruising on that left side, and these patients look ill. Okay, and if there's a lot of bleeding because of all this decreased ability of the acini, then a lot of times you'll see hypertension. Okay, and you're going to treat it as you find it. All right, esophageal varices. These are the coolest things. They're horrible for the patient, but they are the coolest things. And I have run several varice calls, and I'm going to tell you, esophageal varice call looks like the start of a horror movie. They're pretty neat. So the veins of the esophagus wrap around the esophagus, right? And and a lot of times this comes from alcohol abuse, because these veins are linked to what's called the portal system. Okay, so the blood flow is going to flow all through the abdominal organs, through the portal vein, and in the liver. So if you drink too much, you abuse your liver gets fat, and then all of a sudden the portal system becomes very, very, very very pressurized, or increasing pressure, so you have increased portal pressure. Okay, and that's why we say a lot of this comes from drinking. So those portal veins will get really agitated. Okay, and occasionally they will rupture. Okay, and when they do, they bleed profusely. Okay, so these portal veins become really engorged, and then they will get under so much pressure that they rupture. When they rupture, these patients will literally bleed to death. This has a mortality rate of about 40%. Okay, they will be bleeding all over the place. Okay, again, remember your primary cause is alcohol abuse. Okay, that leads to cirrhosis of the liver. Cirrhosis is going to lead us to, and that's going to be the inflammation, death of the liver. Cirrhosis is going to lead to your increased portal pressure, and then eventually those varices rupture. Okay. What you will see is they're going to have initially, they have this painless bleeding, and they're hemodynamically unstable, and they're going to be hemodynamically unstable almost immediately. You have to remember they're going to be vomiting up some blood, but they're also going to be retaining a lot of it in their abdomen. So the blood you see is not all the bleeding that they're doing. It's very, very important. Okay, so they're going to have a lot of bright red blood. They're going to be dysphagic, it means they have trouble swallowing. A lot of times they feel a burning or tearing sensation. As those varices continue to let that blood loose, they're going to feel like they are having a burning or tearing sensation because it's irritating the lining of the esophagus. Okay, because the portal pressure is going to back up into your spleen, and the spleen has to do with clotting. These people don't clot very well. Okay, and this is what alcohol does to you guys. The other thing you have to look out for is, because the liver's damaged because of all the drinking, some of the other clotting elements that work with the spleen don't get produced either, and prothrombin is the one that you most likely think about there. Okay, so these patients can't clot, and they're bleeding profusely, and they've got a bad liver, and they've got a bad spleen. All right, this is why mortality is so high with them. Okay, you can't stop this bleeding in the field. Okay, this is an area where you have RSI and you think you can get this person RSI, you RSI them. Otherwise, you have the most aggressive airway management you possibly can have with the tools that you've got. You're going to have to do fluid resuscitation for them, and these people go emergent to the hospital. Okay, get your suction devices out. If you've got a portable and a wall-mounted unit, I recommend getting both of them. That's what I do. I get both of them out. If my patient's alert, I have him hold a yonker, and I've got another one, and I'm working on it. Okay, because you don't want them to aspirate. Treat them with oxygen. They're more than likely to get hypoxic really fast, so treat them with oxygen if you can. Know that they're going to be in shock, so we need to treat them just like a shock patient. Prevent heat loss, oxygenation, fluid resuscitation is needed. Okay, not a whole lot you can do with this other than try to keep them alive till you get to the hospital. These are really, really cool calls, though, because you are going to have a lot to do. I'm not going to spend a whole bunch of time with hemorrhoids. Hemorrhoids, I think we all know what hemorrhoids are. If you don't, I encourage you to read about them, and if you have specific questions, I'll be happy to answer them. But for the most part, hemorrhoids are not something we need to deal with in the field, and if so, then you can figure it out. Okay. Cholecystitis, all right, that's inflammation in your gallbladder. Again, this can be acute, this can be chronic. Okay. Oftentimes, you're going to see inflammation throughout um, the uh, the abdomen, and it can be all kinds of places. Remember that it's a formation. I'm sorry, it's an inflammation of the gallbladder. Okay, and don't confuse that with cholelithiasis. Okay, and I'll mess that word up, but that's gallstone development. But cholecystitis is inflammation of the gallbladder. Just know that gallstones are going to cause 90% of your cholecystitis cases. Okay, so gallstones cause cholecystitis. All right. More often than not, you see these in obese middle-aged women with more than one biological child, and you see this in obese people all over the place. Um, obese, I'm sorry, obese middle-aged women can also be more closely associated with a type of stone that comes from cholesterol-based development. And that's kind of getting a little deep in the weeds there, but that's kind of one of those things. But women tend to have a lot of trouble with this, but so do obese men in the middle age range group. Okay. Um, a lot of what you're going to see with cholecystitis is an acute attack, and it's going to be in your right upper quadrant. It can irritate the diaphragm a little bit, remember that, and lead up to the right shoulder. Um, if you do have a stone lodge, that pain can be colicky a little bit. More often than not, you'll see this pain after a meal that had a big fat content because it makes the gallbladder release a flood of bile that it can't get rid of, okay? So big fatty meals tend to make this happen. You see this on Thanksgiving all the time, Christmas all the time. Somebody eats a whole pizza, then you're gonna you may have a gallbladder attack. It can look like an MI again. 12 leads is all the rage here to make sure you don't miss something. All right. Do a good inspection of the abdomen. All right. Um, you might want to palpate the abdomen, and if you do, oftentimes you will find diffuse right-sided tenderness, or you'll find it right under the right costal margin. That's a positive Murphy sign. I'll show you in lab how you find Murphy sign. I'll show you what happens if you touch it, because most of the time people lose their mind. For you guys, your pre-hospital treatment for this is going to be position of comfort, adequate oxygenation if they need it, IV access. Dilaudid or fentanyl is your friend here. Morphine is questionable here because it's believed, not for sure, but believed to cause some spasms of the cystic duct. So you want to try to stay away from morphine because that's the thought process anymore, is that it can cause some spasm. And I will try to get you more specific information about how that works, but I know that that's one of the things that's kind of coming about. Acute hepatitis. You see this sometimes as inflammation of the liver. You'll see this sudden onset of malaise, weakness, anorexia, intermittent nausea, vomiting, dull right upper quadrant pain happens with this. You can see this develop into cirrhosis or hepatic encephalopathy, which is going to be altermentation as a result of something going on in the liver and liver cancer. You guys should all have hepatitis immunizations, and you should do good BSI protocols. Okay. Hereditary hemochromatosis is a very common genetic disorder. The body absorbs and stores too much iron. Okay. So joint pain is the most common complaint. Normal life expectancy if it's diagnosed before secondary disorders develop. And I've never seen one in the field, but you can read more about it if you'd like to. But that is kind of the main things that we talk about pre-hospital. I know I kind of rushed through that. I try to keep these at less than an hour. Just remember, pain management is okay now. Good assessment. Check for bleeding. um, and make sure that your patient's not in shock and keep yourself safe. We'll talk a little bit about age-related variations in abdominal pain because that's important for you to understand. Um, know that your causes of abdominal pain in your older population are more likely to be diseases that require surgical treatment. That can be vascular issues, heart disease, sepsis, things like that. Understand that your infants and your young kids can't communicate effectively their degree of pain. They will become sicker faster. They will become dehydrated and septic, especially more quickly. And understand that vital signs do not accurately reflect the degree of illness. Understand kids will compensate until they die. They don't demonstrate that decompensation mechanism that adults do. Kids compensate, 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 and then they die. And you've got to be aware of that. Okay. And folks, that is where we are. Again, I want to remind you, don't fall to the myths. We're going to treat these patients with pain medication as needed. And let me know if you have any questions.